We are very excited to get started tonight with our mini orthopedic lecture series. We're hoping that this can provide some important information that can be placed on our website and easily accessible to patients. We take great pride in spending time in the clinic and discussing things at length, but sometimes there are questions that go unanswered. So being able to direct patients to these resources will be extremely important. And so please, if you have any questions, I know there are a few patients from the past, a few current patients, and a few future patients that are going to have some of the issues that we're going to be talking about tonight. So please chime in with any questions or concerns, and Desiree will interject and we can answer those. Otherwise, we will have a little question and answer session at the end as well. So without further ado, let's get started on this presentation, and hopefully, again, it provides some needed information. So we're going to start with the knee, and we're going to start with a structure in the knee that pretty much everybody has heard about, and this is the meniscus. Before we do that, I was just going to introduce myself a little bit more. I grew up in the Midwest. I grew up in Wisconsin, in La Crosse, on the western border of the state, so right next to Minnesota. Go Minnesota Vikings, not the Packers. And I did my undergraduate training at a school in Wisconsin, University of Wisconsin-La Crosse. And actually at that point in time, since it's been a little while, I was able to get an undergrad degree in physical therapy. And so I worked as a sports outpatient physical therapist for almost 6 years in Cleveland, and ran an outpatient clinic, and then decided it was time to go to medical school. So I was fortunate to be able to stay in Cleveland, and I went to Case Western Reserve University for my med school training. I did a combined Master's of Anatomy program at the same time, just because I thought it would be beneficial as a surgeon to have as much anatomy as possible. And then after that, after those 5 years, or after those 4 years of med school, I was able to stay in Cleveland, and that's where I did my orthopedic surgery residency. We then moved to the West Coast, and I did a sports fellowship, an additional year of specialized training in Los Angeles, having great involvement with sports medicine, minimally invasive arthroscopic surgery, and reconstructive surgery as well. So that's just a bit about me, but the real reason why we're here tonight is to discuss the meniscus. And like I said, most people nowadays come in and a lot of the first words out of their mouth is, I think I tore my meniscus. So it's a well-known injury pattern. It's actually probably the most common soft tissue injury in the knee, with approaching probably 1 million type of arthroscopies per year in the United States to deal with the meniscus. We'll get into the weeds of this a little bit more, but there are typically two types of tears. There's the young 20-year-old athlete, high school athlete, who has a traumatic twisting event where they are playing a sport or they're in a deep squatted position and the meniscus gets caught and it tears. And it may involve a ligamentous injury as well, like the ACL, PCL, MCL, or LCL, but it may also happen in isolation. And then there's another group of patients, the more mature population, who may have an injury, but also may just have what we term degenerative meniscus tears. And hopefully one of the take-home points after this discussion tonight would be for people to understand the importance and the difference between these two tear patterns, especially as we talk about the treatment. A little bit of anatomy. If you look at
really quick.
Sure.
Dr. Fortun, sorry to cut your thoughts there.
Right.
Could you explain what the acronyms were for the PCL, and I think you said the LCL? What does that stand
for?
for?
So actually that's perfect, because if you look at the screen now, you'll see, I'm going to adjust my pictures here. You'll see the anatomy. So this bottom right picture, we're looking at the front of a knee. And the LCL is an acronym for lateral collateral ligament. So the collaterals are the side ligaments. So there's the one on the outside of the knee, if you follow my cursor, and then the one on the inside of the knee, and that's the medial side of the knee, and that's MCL. And then your cruciate ligaments, if you think of cruciate, that means cross. So they cross in the middle of the knee. And the one that everybody has heard about is the ACL, or your anterior cruciate, meaning it starts from the front of the knee and goes to the back. And then the PCL, or your posterior, and sometimes people remember posterior as your backside or your buttocks, and so it's the back side of the knee coming forward. So those are the ligaments that can be injured, and it's oftentimes the ACL with a meniscus tear. But again, you can also have the meniscus tear in isolation as well. So hopefully that helps with those acronyms. And then a little bit more on the meniscus is if you take a look at that top picture, you can see the two meniscus. So the top of the picture is the front of the knee. This is the back of the knee. And then you have the outside and the inside, and you're looking down on top of these crescent-shaped or C-shaped structures. And that is your lateral, which is the outside portion of the knee meniscus, and then the medial meniscus. And they're very similar in shape, but the medial meniscus is a little bit less of an acute C shape, a little bit bigger. And on the average, you probably have more medial meniscus tears for various reasons than you do lateral meniscus tears. This is also what we term fibrocartilage. So the best real life, kind of especially on the coast here, as far as an analogy, is a piece of calamari. So if you squish that between your fingers, you would notice that it has some resistance, but it does compress and it doesn't fall apart with some of that compression. And that's kind of similar to how a meniscus or a human meniscus feels. And the reason it is like that is because of what's inside of it. So it's got fibers that go all the way around. It's got fibers that go front to back. And it has all these disorganized fibers that really give it the ability to absorb cushion or shock and also distribute force, as well as act as a little bit of a stabilizer because it has that cup shape to it. Another important anatomical feature, which I actually have had patients bring up without me even talking about it, is the blood supply. And there's been some landmark studies that have looked at the blood supply, because if you don't have a good blood supply, you're not going to be able to heal the meniscus, whether you repair it or don't repair it. So the picture on the right is the meniscus, and you can see the outer edge is red. Doesn't look that way when you're looking at it through a scope, but that's to depict the blood supply to the periphery of the meniscus. If you cut it in cross section on this left picture, you see it's all red, great blood supply. The inner edge of the meniscus has a very poor blood supply, if at all, and gets most of its nutrients from just the joint fluid. So there's a very poor response to healing if you repair just that inner edge. So we really like to try to repair the red zone. And in some patients, young, healthy non-smokers, we like to repair that red-white zone. If we talk about function, this is just a diagram to show the one on the left is without a meniscus, the one on the right is with a meniscus. And really it has two important jobs. Number one, most importantly, it distributes the force. So it's more contact area, so there is less precise force. So if there is no meniscus, that's pushing directly on the cartilage, and that's going to wear out faster. It also kind of gives this ball shape a little bit of stability. The end of the femur or the thigh bone has a ball shape to the end sitting on the top of the lower leg bone. And the meniscus helps to provide stability, but again, more importantly, distributes the load evenly. If we go back in time, and go back in time quite a bit into the early 20th century, mid 20th century, and even into the 19th century, the meniscus was thought of as a vestigial or non-necessary component of the knee. And if you look at some of the European studies in soccer players, because of the heavy amount of twisting and turning, they had a lot of meniscus injuries. So there was a time, probably 50, 60 years ago, where they would go in prophylactically and remove meniscus before the season just to keep them from being injured. And then as we found out that that wasn't a good idea, they still would be aggressive at removing the meniscus when it was torn. We now know today that that's not a great idea. So this is a picture of x-rays, sequential x-rays moving from left to right. And this is the inside, or that medial part of the joint. And this first picture is 7 years after that medial meniscus was removed. And you can see that the space between the two bones is certainly less than the outside, but there still is space. Then you progress to 13 years after the meniscectomy, or the removal of the meniscus. You can see less space. You can see white lines or thickening of the bone. You can even see some bone spurs developing. And then 21 years later, after that complete meniscus had been removed, you really have what we term end-stage arthritis. And at that point, the meniscus doesn't matter. It's an arthritic process, the knee's worn out, and really you're talking, the only surgical option is a knee replacement. So we know that we want to preserve the meniscus, and that's really, within even the last 5 years, there's been a lot of technology and research and instrumentation that help us preserve the meniscus. So if we look from a top-down approach at the meniscus, there are different types of tears, and I won't bore you with this, but basically the importance is how displaced it is and how much it can affect the joint. So if you have a longitudinal tear, you may not know that, but if that extends and that piece flips into the joint, you may not be able to fully move your knee. You may not be able to straighten it. You may not be able to bend it. You'll have pain and what we term mechanical symptoms, which are clicking, catching, locking. Sometimes a parrot beak tear acts like a hangnail. And I had one of my professors way back when describe it this way. Sometimes that hangnail sits right next to the meniscus and it has a tear, but it's not displaced, so it doesn't hurt. And then all of a sudden, whatever causes it to flip into the joint, you catch that hangnail on a sweater or on a door or something, and then you get pain. So these are the bad players. They're the ones that you may need to go in and fix or remove, and then you will get better quite readily. So they're all different types of patterns, of course, but those are the things to consider. So we talked a little bit about the injury pattern and the importance of knowing if it's in a healthy knee versus a more mature knee. And so this, if you're thinking about, well, do I have a meniscus tear or what happened? These are some of the common injury patterns. So it may be an athletic injury where you're twisting or turning. It can also be where you're bending over and you stoop to the floor. Maybe you're painting or picking something up. I had a patient come in today with a meniscus tear that he was in a tight space, he was in a crisscross position, and he tried to stand up with his knee twisted, and he felt the pop, and he's got an MRI with a meniscus tear. And he's a young patient with a healthy joint, so that's certainly something we want to try to repair. You'll have pain right at the joint line, we call it. So that's where the thigh bone meets the lower leg bone. You may have catching, locking. You may have a sense of giving way, and you may even notice some swelling in the knee. So if those are concerns of yours, that's something that we would want to see you for. And what we're going to do is perform first and foremost a clinical exam. So we're going to look at your knee, and the top picture is of a patient standing facing us, and you can see on the picture, the right side of the picture, you can see a knee that looks different than your normal knee. And it's really these dimples on the inside and outside just above your kneecap that start to fill with fluid. And we call that a joint effusion. And basically it's a swelling of that joint. And usually with an acute or a recent meniscus tear, it tends to swell quite readily within the first day or so. We'll also push on that joint line, which is depicted here by that line, and look for tenderness. Another good test is if it really hurts when your knee is forced all the way back with your heel to your buttocks and you're flexing that knee as much as possible. There are some special tests which we don't need to go over. They're not as reliable anyways. It's really these top 3 clinical signs that we look for. We'll probably always get a set of x-rays just to make sure that there's not a broken bone or there's advanced arthritis or there's some abnormal anatomy or there's a loose piece somewhere. This is just a standard x-ray and obviously a normal looking x-ray. If you don't get better and we suspect a meniscus tear, oftentimes we'll take the next step to image it further, and that might mean an MRI. So this is a picture of a normal MRI on the left and a tear on the right. So these black triangles are basically us cutting the knee front to back. So you see the front edge and the back edge, and you should see a nice, consistently black pattern to the meniscus. If you see a little white in the middle, but it doesn't extend to the top or the bottom, then we don't consider that a tear. That's an intra-substance change, we call it. But if that tear extends and you see that white line going to the bottom or the top, that is a tear. And if you remember what those tears look like, you can imagine that extending either along the length of the meniscus or even towards the middle of the meniscus. But if that is diagnosed and if you have failed other non-surgical treatments, then sometimes we talk about surgery. So what goes into those decisions? So obviously, if we could treat everything without surgery, that would be great. And we always try to do that, and that's certainly our goal, but sometimes surgery is an option or the best option. So if you have a small tear, less than a centimeter, you don't have any clicking, catching, locking, you've gotten better with rest and ice and some anti-inflammatories or some physical therapy, you can certainly treat a small tear without any type of surgical intervention. And if it is in that red zone and it's really small, it may actually even scar in on its own. Obviously, if you're a mature patient and you've had some wear and tear in that knee and you have advanced arthritis, the meniscus doesn't really matter anymore. Now, if you had minimal arthritis or even a little bit of arthritis, but mechanical symptoms of catching or locking because of a new tear in the meniscus, sometimes we do consider trimming that out to get rid of those mechanical symptoms. But that's a lot of discussion with you, the patient, and the family to make sure that you understand that we're not treating the arthritis, but we're treating that new meniscus tear. Now, which of these are going to cause us to consider surgery early on? So if your knee is locked, if you have that bucket handle tear where a piece of meniscus is stuck in the joint, that is something that we're going to talk about surgery early on. You, of course, are going to make the decision, but we're going to discuss the pros and cons of that. Or if we know that you have a small tear and you've failed all of the other conservative options, meaning you didn't get better with physical therapy, we maybe even tried some type of injection, you rested it and you're still having pain, then we would talk about going in there and taking care of the meniscus. So before we move on to some of that treatment, we need to talk about the term degenerative knee scope. And this has garnered a lot of attention in our orthopedic literature, but also in general medicine literature, and even in, if you search the New York Times, they had some articles on it too. And that's because of that first slide of 750,000 to 1 million knee arthroscopies done per year for quote unquote meniscal stuff. And so what has happened in the past is that people would come in and get a diagnosis of a meniscus tear, whether it's by exam or MRI, and they may be more mature and they may have some degenerative changes in it. And really the problem is the arthritis, not the meniscus. But somebody goes in and cleans up the meniscus and you feel better for a bit of time, but then a year later you're back for a knee replacement. So we try hard not to do that, and we advise you that that's not a great idea, because at that point, this arthritis that you see or the wearing away of the cartilage is really the problem. Now, again, there's always it's a bell-shaped curve, so there's a gray zone where you may have some arthritis, but you had no pain before the injury, and now you have a meniscus tear that's causing clicking, catching, locking. Then we would talk about maybe it being necessary to go in and get rid of that portion of the meniscus. So again, keep in mind that degenerative meniscus tear may provide some short-term relief, but it's certainly something that you need to have a discussion about. These are some pictures inside the knee. So this is what it looks like when you're in the knee doing a knee arthroscopy. And again, arthroscopy is accessing the knee through millimeter size incisions and getting camera and tools in there. The picture on the left is the end of the femur, which is the ball. The meniscus is that tissue in between, and then your tibial plateau, or the flat surface of the top of your tibia, which is your lower leg bone. So again, if you remember that schematic with the ball sitting on the tabletop, you see the ball here, and this is pretty normal looking cartilage. It looks like a cue ball if you were playing pool. But you can see that this cartilage is starting to look a little different. It's looking a little soft. It's looking a little frayed. You can see a little meniscus tear, but that's mild arthritis. If you go to the middle picture, you see more fraying. It kind of looks like a sea anemone, but there's all these fronds. You see thickening of the cartilage. It does not look nice and smooth. And then this is what we call a grade 4 defect, which is the most significant defect, where the cartilage is completely gone and all you see is exposed bone. You can tell this is a picture of a younger person because the cartilage is pristine, but for whatever reason, they had an injury that cracked the cartilage and then it widened and now you have exposed bone. So that's an issue because we can't get these chondrocytes or these cells to grow new cartilage again. So there are some restorative cartilage procedures that we can do, but we have not developed a way to regrow cartilage, unfortunately. So this is a picture of a degenerative knee scope. So you can see on the left, it's the same knee on the left and the right, but this person went in and they had a meniscus that was clearly torn, but it's more of that macerated, kind of looks like crab meat type of appearance. It doesn't really have a piece that's probably sticking into the joint. It may be causing some pain, but a lot of the pain is from the cartilage not being healthy. So even at the end, it might look a little prettier, it might look good, but that meniscus is not going to cause any issues. This arthritis is going to cause problems. And we don't know how that arthritis will progress. If you're healthy, if you have good alignment, if you have healthy weight, maybe it doesn't progress. Some of it's also genetics. Some of it's what you do. Are you avoiding impact activities? All those things go into how this is going to progress. But again, it's an arthritis problem, not necessarily a meniscus problem. So what are ways that we would use to treat you without an operation? So RICE is the acronym most people have heard about. We rest it, and that's just relative rest. It doesn't mean you sit in bed. It just means you avoid the activities that hurt it. You might ice it, you might compress it, you might elevate it. It may be physical therapy to work on the strength. The physical therapy, sometimes this is a question, how is physical therapy going to change a tear in the meniscus? How is physical therapy going to change a rotator cuff tear? And it's not going to help those anatomically, but if you can make that muscle around the knee stronger and get your balance better, it may protect the knee so that the meniscus tear either might heal or it may not be bothered. Sometimes we also have to step up the game a little bit and use injections. So cortisone is an anti-inflammatory. It's a catabolic steroid, which means it has the capability to break things down. And we still use cortisone a lot in the correct situations, but there is some literature that talks about repetitive cortisone injections. So for a young, healthy knee, we do not like to do cortisone often. I may give it one chance with cortisone, but that's probably it. Gel injections it's called a viscosupplementation. It has molecules in it that are similar to your cartilage, and it's designed to really limit the swelling in the knee. It's not going to regrow cartilage. It's not going to make your knee perfect, but sometimes if there's some arthritis in there, that might be an option. The final type of injection are what we call orthobiologics, and these are things that you are starting to hear about in the literature and even in the general public now, but stem cell therapy or bone marrow aspirates, where you take bone marrow and get cells out of it, or platelet-rich plasma, where we take a blood draw and spin it in a centrifuge and get the platelets, which are cells in your bloodstream that can basically kind of trick the body into thinking that there's a new injury and use its own resources to help stimulate a decrease in the immune reaction and helping to limit the pain and the swelling. So some of these things have been shown to be effective in the literature. But if none of that helps, then we talk about surgery. And so arthroscopy, like I said, is like the picture on the right, exactly what it looks like. We have a camera that we're looking at. We have a small, tiny incision where the camera goes in, and then another small, tiny incision where our tools go in. So some of the terminology, we're talking about the meniscus, but if we remove part of the meniscus, that's a meniscectomy. It's removal of it. And we only want to remove the parts that are torn, and only if we don't think they're repairable. If it is repairable, if it's a healthy patient, young, the knee is healthy, it's in the right zone, then we will put in some stitches, and typically we put them in all through those little incisions with no external incision or big excision or incision. If somebody had a massive tear of their meniscus and the meniscus was completely gone, or 10, 15 years ago, they had a meniscus that was removed, we do meniscus transplants, but those, again, don't work as well as they sound, and certainly they're not as easy to do as they sound. And it's more a last resort for a young patient with a pristine, non-arthritic knee, nothing else wrong with the knee type of situation. So here's a couple pictures just showing again, you can see the femur or the thigh bone. This is the camera and the tool. So there's a little tear in the meniscus. And in this case, it was on that inner zone, so where there's not a good blood supply. So we basically reshaped the meniscus and it looks normal again. It's just a little bit thinner from front to back. But it's really important to leave as much of that meniscus as possible. And it's important that it never goes all the way through, because if the tear goes all the way through, that can disrupt we call it the ring effect of the meniscus, and it loses its stability. So here's just a couple pictures of a meniscus, and this is a scope picture on top, and you can see the probe pulling the tear in. So that's almost like a parrot beak tear. And then we just trim it out and make sure that we leave the cartilage looking nice and perfect. Here's one that already had some arthritis in it and a tear. And you can see that we smoothed out the cartilage and smoothed out the meniscus, but at some point that arthritis is going to become a problem. These are just a few final pictures of the stitches. So most of what I would do is all inside. So it's these little devices that go in, place a knot outside of the meniscus, and you can do it all from the little tiny incisions, and you can repair the meniscus. This is a picture of doing a meniscus repair. And this right here, it's hard to tell, but that's a probe, which is a little metal projection in the tear and pulling it forward. And then you can see a couple little stitches in the meniscus in the way back, holding that meniscus in position. And lastly, this is what it looks like if you did a meniscal transplant. And so this is a cadaver meniscus going in again through an arthroscopic portal and going in and basically taking the place of a meniscus that's completely gone. So last few slides here, but these are some of the main differences, and these are some of the things that we would talk about early on and make sure that you as the patient completely understand, because the rehab and the recovery is vastly different. So if we go in there and trim out the meniscus a little bit, because we think that's the best thing to do, I typically keep you on crutches for about a week. You can put some weight through the leg, but they're there to keep you from doing too much and to keep the swelling down. But if you're healthy and the rest of your knee is pretty sound, you're typically off the crutches in a week and you're doing some physical therapy or doing your own program at home, and you're back to normal within 4 to 6 weeks. If we have to repair the meniscus, now we have to wait for something to heal. So you're actually on crutches for almost 4 to 6 weeks before you get rid of the crutches, and you're not returning to normal activities at least for 3 to 4 months. But yes, Desiree.
Apologies. I'll let you finish what you were going to say there, and then there's a question that just came in the chat. So you were just saying return to activities 3 to 4 months. What were you going to say after that?
That is where I was going to end, so it's a perfect time. Go ahead.
Okay, so one of the questions was, what is a young patient, like the age or how it looks?
So chronological age is not as important as the age of your joint and the age of your tissues. You can have somebody who might be 60 who has cartilage and physiology that's better than a 20-year-old. So you really have to assess how the cartilage looks on X-ray, how the cartilage or the kind of the signs of the cartilage looking on X-ray, how the cartilage looks on MRI, and then the health of the patient. So are they medically healthy, or do they have all these medical comorbidities, heart attacks, strokes, or on blood thinners? A big one, honestly, and it's hard for people, is smoking. Smoking obviously has a lot of deleterious effects, but it affects the joints and the tendons and health of those structures as well. And it also is very important for tissue healing. So if we have any sign of an inability of things to heal, then we're going to be talking about kind of removing that portion of the meniscus. And if you had to hang your hat on an age, you would probably consider that 30 to 40 year range the more mature patient population. And so you would have to critically look and make sure they're healthy enough, and make sure the cartilage looks perfect, and make sure the tear is in the right spot to consider repair. Because if you do a repair and the body doesn't heal it, even if you did the repair perfectly, then it may re-tear and you would have to go back in and take out that torn piece. So you just want to make sure that every type of surgery is indicated appropriately. I hope that answers our question. If not, send something back through the chat. All right, so the last few topics here are, what does the future hold for the meniscus? So again, take home points, preserve your meniscus. So hopefully if we're talking about this in the clinic, we'll discuss all this, but if you've moved, if you're out of town, if you're talking to another orthopedic surgeon, you want to talk about how is it possible to save my meniscus, and make sure that they can give you information to make a sound decision. So in general, we want to preserve the meniscus. I also want to make sure everybody's aware that there are differences between those acute traumatic tears in a young healthy knee versus a degenerative tear, and why we treat those differently. So what does the future hold for this? So we want to make sure that how can we enhance the healing of the meniscus? So if I go in there and repair a meniscus and we're not doing a ligament surgery where we're going to cause a lot of bleeding into the joint, we actually drill into the bone to get the bone to bleed, and that's going to allow that meniscus to heal. So there are ways that we can use things called fibrin clots, or even that PRP where we take your blood and spin it down and put it into the joint. At some point you can talk about meniscal replacement, but again, like I said, that is not a perfect science. There are other things that are synthetic. Sometimes there are 3D printed models that can be used for non-human tissue. You can poke holes into the tissue. It's called trephination, and that can help with getting blood supply to those areas. So there's things that can be done to try to enhance it. But that's the end of my presentation, and I'd like to thank everybody for their attention. And if there are any questions, we can certainly discuss those.
There is a question here. It says, I read online about stem cells for knee tears. Do you use this?
So yes, we do. That falls under the category of orthobiologics, and that is something that has now been around for 5 or 10 years, and it's something that's not going to go away because we're going to get better and better at it, but we don't know enough about it to use it reliably. So we do, just to answer it, I guess in a long fashion, PRP, which is where you take your blood, you spin it down and you get the platelets, that has no stem cells in it at all. If you're going to be harvesting stem cells, the best place is to harvest it from your own tissue. And even in the best of spots, the active stem cells that can turn into a specific cell type and start producing, for example, a chondrocyte produces cartilage. For it to truly be termed a stem cell, it has to be able to turn into a cell that can produce what you want it to. It also needs to produce other stem cells that can be turned into different things. And so our ability to get those cells to produce what we want it to, harvest it, inject it into a joint, get it to go to the right spot and seed there and start producing cartilage, that's not happening yet. Now, there are still some early literature that talks about the benefit from functional standpoints and pain reduction of taking stem cells. And usually we take it in the operating room. So we'll use a device to get some stem cells out of your pelvis bone. And right now we can't modify those. So you can't send them off and proliferate them, but you can spin them down on the back table and you can re-inject them into the knee. And there is some early literature that can help with pain control. But probably what it's doing is modifying the environment and getting rid of some of the cytokines or some of the other markers or cells that are there for inflammation, and it's helping reduce those. It is not, despite what anybody might tell you, it's not regrowing cartilage. But we do use them in certain situations if it's appropriate.
There actually are a lot of great questions coming in, Dr. Fortun, so thank you so much. This has been really insightful so far. The next question is, what exercises should be avoided if you have a knee tear?
So if you have a meniscus tear and you're trying to treat it without surgery, you're going to want to avoid anything that's going to propagate or lengthen that tear or stress that spot. So hopefully if we've had an MRI, we know if it's in the back or the front, but in general, it's twisting type of activities. So if you go back to a sport like soccer or basketball and you're planting and you're twisting at the knee, that's going to not allow that meniscus to calm down. And I use the word heal cautiously because it typically doesn't heal, but if it's tiny and it's in the right spot, it might. But it's those situations where you're twisting or you're squatting really deep and you have deep knee flexion, you'd want to avoid that. If it's in the back of the meniscus, just standing up from a chair with your knee bent and putting a lot of weight through it can also squish that part of the meniscus. So you don't want to have another injury pattern playing a sport until your symptoms have completely resolved.
Here's another one here. I'm an avid runner, just love running. Should I continue doing so?
So I'll answer that in the way I think they're intending. So running is great exercise. It's easy to do. It can burn calories. It doesn't require special equipment or a gym. You can be on vacation and decide you're going to run. And it is a loaded question because everybody's different. So people's alignment are different. People's body habitus or the way their body's shaped is different. People's weight is different, and their injury patterns are different. So if you are enjoy running and it's a mental release, certainly that's something you may want to continue with. If you have an arthritic knee and you want to preserve that knee as long as possible, you may choose to not run for exercise, and you may choose to get the same benefits from a cardiovascular standpoint or a general health standpoint by doing non-impact things like biking, swimming, elliptical, anything that avoids that constant compression. Certainly, if you have a meniscus tear, but your knee is healthy, straight ahead running might not bother your meniscus at all because it is more the twisting and the deep knee flexion. So if you have a healthy knee and you've taken care of yourself and you like to run, you can still run, but you certainly have to take some of those other things into account if you have any bit of arthritis in your knee.
There's another one that just came in. I'm signed up for the Battleship Half, but was told I have a meniscus tear. Can I safely participate?
Good question. Obviously, it depends on how your knee looks. And again, without all the information, I'll try to answer the question based on what I might see. So if this is an acute, meaning that meniscus tear just happened and your knee is swollen to the size of a grapefruit, it's an easy answer. That answer is no. Obviously, you're in charge, and if you choose to push through, you can, but the chances with a big swollen knee is to make that swelling worse. And it can inhibit the muscles around the knee. So if you happen to step on a little rock or step in a hole and those muscles can't respond appropriately to stabilize the knee, you could further injure the knee and tear one of those ligaments or have another type of problem. If it is an older meniscus tear and you've been told you might have a meniscus tear, but you're not having any mechanical symptoms of catching or locking, you have minimal pain and minimal swelling, then you're unlikely to make it worse if you want to go ahead and do your normal activities. And so if with these small tears, even if we diagnose them by MRI and you are somebody that can handle it or manage it from a conservative standpoint, non-operatively, and it's not causing mechanical symptoms or flipping into the joint surface, and it's just a tear in the periphery and it hasn't displaced, you can try to get back to all your activities that you want to do, and that's fine. And you're not really at risk of making anything significantly worse.
All right, and there's another one too here. Do you recommend any OTC supplements that claim to support joint health? Would this help to avoid injury and ailments in the knees?
So there are no level 1 strong research studies that have supported joint supplements, although anecdotally, meaning just from what patients have said, and these are people that are doctors, that are healthcare professionals, things like glucosamine and chondroitin, which you can buy at your local big box store or your local drug store, have been shown to have some effect. And again, it's not level 1 research that has shown cartilage to be restored or preserved. But again, I know a lot of people, even in the healthcare industry, that claim that that does help. There have not been any studies to show that there's any downside to taking those. So that certainly is something that I routinely recommend for joint health and preservation if they want to take something. Obviously, any anti-inflammatory supplements can also be helpful because the arthritic process is an inflammatory process. If you have medical issues that involve inflammation, whether it's GI stuff or other inflammation throughout the body, and you reduce that by healthier eating or non-smoking, etc., that can also help with your joint health. So certainly a overall holistic approach to decreasing inflammation throughout the body is good. And I mean, the most well-known supplement is glucosamine chondroitin.
All right. Are there any other questions that anyone may have? You may feel welcome to unmute yourself, or you may send it here in the chat. We'll wait a few moments, and then I do know that we have a patient here that's joined today that would be open to sharing her experience as well. Oh, here's another question really quick here. Dr. Fortun, are burpees bad for the knee?
Not necessarily. And for a lot of these CrossFit type exercises or total body exercises or things you might have done in high school sports, they're all fine and well, but you have to consider what you're going to get out of them. So if it makes you motivated mentally to do a burpee because you feel like you're young again and you can do it in a safe environment, I think that's great. If you have arthritic knees and every time you do it, it hurts you and you swell, then clearly it's not a good idea. And you can still get strength and cardiovascular fitness in other safer ways. But no, I mean, if you can do a burpee and a total body type exercise, whether it's burpees, jumping jacks, whatever you want to do, that is fine as long as you've taken care of yourself in a manner that those type of exercises are appropriate.
And Casey, I see that you've joined today. Don't know if you can hear us here pretty well. Hey, I see you unmuted yourself.
Yeah.
There. Thank you so much again for joining tonight, and thank you.
Of course.
Oh, you're so wonderful. Thank you for being open to sharing about your experience. What feedback would you be open to sharing with a future meniscal tear?
Yeah, has anybody that's on the call had the surgery yet?
I believe this is Fortun, and I think Julia is on the call still, and she had a meniscus repair last year. Is that correct?
Okay.
Julia?
Yes.
Okay. Yep. So I just had mine on July 28th. Be an easy, I say easy, trim repair. So the repair. Here I am. I'm 3 weeks post-op. I had my 3-week appointment yesterday. It's a lot, I have to say. I wasn't prepared for all of the knee brace crutches moments. I never had any kind of surgery besides having C-sections with my children, so it's definitely a lot different. I'm definitely looking forward to having my knee not hurt anymore, and resuming as much activity as I can that I was doing prior to the tear. But yeah, I mean, so far, so good. It's definitely a learning curve, not being able to walk, properly like I was in the past, or do a lot of the exercising that I was doing was a big struggle for me, but I'm doing okay. yeah, I mean, definitely any questions anybody has, feel free to ask.
And so Julia is a ways out now, and maybe Julia, you'd like to comment now that you're further out.
And actually, there was a question before Julia starts for Casey. And the question is, how did you tear your meniscus?
I honestly don't know. I do think it was probably some kind of squat, because I ran, I mean, I've been a runner for many, many years. I don't believe that it was anything running. And I don't know if you're familiar with Orange Theory Fitness, but it's a lot of cardio and rowing potentially could have done it too. I mean, it's a lot of knee bend, but if I had to guess, it was probably some kind of deep squat or just a wrong turn of my knee. And I remember the day that I did it. I just don't remember what activity I was doing because my knee hurt really, really bad. I couldn't put any pressure on it. And then I went to my primary care doctor the next day, and, you know, she just kind of said, you know, I can tell it's a little bit swollen. You know, we didn't do anything further because it was like the first time I've ever had a knee problem. So I really can't pinpoint the exact activity to how I tore it. I really don't know.
And that can be very common as well. I mean, especially for situations like Casey described, where it might be a squatting episode and you have caught the meniscus, and it doesn't have to be a huge trauma for these meniscus to tear.
Right. Yeah. I mean, I definitely don't think it was, because I think I would have remembered, you know, what I did. But I do tell you, the pain never really subsided. I just kind of babied it and did what I could for it. But it does get worse if you don't get it taken care of. I will say that.
Thank you, Casey, so much for sharing that.
Of course. Of course.
Yeah, and then go ahead. I know Dr. Fortun had a question for Julia there about her experience as well.
Julia, do you feel that you have fully recovered from your meniscus surgery at this point?
Yes, I've definitely recovered from the surgery. It was a little over a year ago. It was 2 days before we shut down the pandemic last year. So it's been a little over a year. It's definitely healed. I have random like aches and pains, but I think that's just because I push it a little too hard sometimes. But I had been having knee problems for a while. Dr. Fortun actually did my hip surgery a year before he did my knee surgery. And I went to my post-op for my hip surgery and said my knee hurt. He was like, all right, let's take it one step at a time. And then, so I healed my hip, and then my knee was getting worse. So we did my meniscus surgery, and it was a long recovery. It was not fun or easy, but it's definitely better than it was before.
Well, thank you everybody for sharing, and I'm sure this will be very helpful to other patients as they hop on this taped experience that we'll post online.